Hello everybody, welcome to QI Talk Time, our first QI Talk Time of 2019. Today the Talk Time is on collective leadership to enhance team performance and safety culture, and I'm delighted to have both Eilish and Aoife with me today. Both Eilish and Aoife, I skipped on a slide, work in UCD Health Systems. Eilish is the Professor of Health Systems at UCD with a team whose research activity is focused on systems and implementation science using participatory and co-design principles. She's been awarded the HRB Leaders Award in 2015 and is the principal investigator of collective leadership and safety cultures called the Co-Lead. It's a 5-year programme in developing and evaluating a collective leadership intervention on team performance and patient safety. So thanks a million, Eilish. And I had the pleasure of having Eilish actually lecture me years ago in a master's in Trinity, so it's great to connect back again. And also we have Dr. Aoife de Bruin, and Aoife works with Eilish in the Health Systems Group in UCD. She's a chartered psychologist with the British Psychological Society, and since joining the UCD Health Systems in January 2016, she has been working on the HRB Collective Leadership and Safety Cultures Co-Lead Research Programme. Okay, so a little bit of housekeeping just before we hand over to the speakers. So we want this to be as interactive as possible. So there is a chat box function up at the top right-hand corner of the screen. If you have any comments or queries or questions that you want Eilish and Aoife to deal with, please put them in throughout the webinar. We will deal with them as we go along, and we'll also have time at the end to come back to those. And the telephone number is there for you, and it's also in the chat box, so please dial in if the sound isn't great over the laptop. And also we are on Twitter, so if you're in a room together watching this, please take a photo, send it over Twitter, and we'll be sending out some tweets during the webinar as well. So without further ado, I'm going to hand over to Aoife and Eilish.
Thank you, Roisin. Hello, everybody. So Aoife and I,
there we go.
Let's get us both on the camera. Aoife and I are going to do a double act on this today. So I'm going to start off by talking a little bit about the background to this program of research, and also the concept of collective leadership and why we think it's important in healthcare and why we started this program of research in the first place. It's quite an extensive program, so I suppose today we're going to focus on the kind of overview of the 5-year program and a little bit on the early stages in terms of our reviewing of the literature and our initial phases in the co-design aspect of the collective leadership intervention. We will be doing further webinars on this in the future as we go through the program, and we'll share more detail of the intervention components of collective leadership with you in hopefully the next webinar, which we haven't set a date for yet, but will hopefully be not in the too distant future. So I'd like to start off, I suppose, by talking a little bit about health systems and the complexity of health systems and why health systems, because of its complex nature, requires a different type of leadership. It has been, I suppose, described as a pluralistic domain, particularly by Jean-Louis Denis, who has done a lot of work in health systems in the Canadian system. And a pluralistic organization, I suppose, an organization that has several diverse goals, but also a diversity of actors and power relationships within it. And I think most people would agree that health systems is recognized as a complex, pluralistic system. The implications of this are that formal leadership and team membership changes very often within such a complex system, and I think people, particularly those working with the HSE, can recognize that this is a strong feature of the system here in Ireland, this frequent change of leadership. I suppose another challenge is that leadership styles often differ among formal leaders, so you can't have uniformity of leadership approaches and styles across the system. That's very difficult to do. Communication across specialties can be formal, but it can also be informal, unstandardized, and fragmented. And because of the interdependencies across specialties, this is a particular challenge in terms of leading a system like this. I suppose the other issue, which we'll talk a little bit about later on, is that, care has changed and evolved, and it's no longer contained within a unit or a small group of people. It's something that evolves over days, weeks, or months. And although there is still a necessity for a core team of clinicians providing bedside care, there are greater numbers of consultant clinicians and members of staff who join the care team for specific brief episodes centered around specific tasks or specific purposes. And this applies very much, I suppose, to the allied health professionals and to specialties outside of the kind of core specialties that the patient might be admitted to, and that's partially because of comorbidities and the complex nature of the healthcare issues that we're dealing with in today's world. So moving on, I suppose, to talk about leadership, and there is a kind of constant, I suppose, refrain about leadership being a problem in healthcare. And if we look at some of the investigations and some of the, I suppose, major errors that have occurred, not just within our own healthcare system, but I think within the NHS system as well, a lot of these inquiries and reports point to leadership as a problem, as a core problem within the system. So if we look, for example, at the Bristol inquiry, it talks about a lack of leadership and of teamwork. Poor teamwork demonstrates a lack of effective clinical leadership. Power but no leadership, which is an interesting one. And there's a lack of leadership and insight, which is another important, I suppose, component of leadership. The Mid-Staffordshire report, again, there's a lot of talk here about the disengagement from management and leadership responsibilities, requiring to remedy leadership, serious signs of deficiencies in leadership, and calling into question the competence of senior management and leadership at the trust. So I think there have been a lot of, I suppose, attempts to identify leadership as being the core of the problem in terms of healthcare errors and in terms of safety issues. If we move on to looking at the cervical check inquiry by Gabriel Scali, again, I suppose less direct criticism of leadership here, but nonetheless it is there, particularly around clinical leadership. So it is an issue certainly within our system as well. So I suppose, you know, the question arises then in terms of what we expect of leaders and leadership, and are we expecting leaders to be all things to all people? Are we expecting too much? You know, and I suppose we traditionally within the leadership literature, there's very much a focus on the individual, the great man or the great woman, and identifying a set of traits or characteristics that define the leader. So rather than focusing on the actual work of the leadership, it's about the characteristics of the individual. And I suppose it's really important in terms of the complexity of healthcare that we start recognizing the social and historical context in which the work of leadership takes place. So leaders are not the same, and the requirement for leadership can be different in different types of organizations. And particularly, I suppose, in healthcare, when we talk about, you know, a pluralistic organization that has a diversity of goals and a diversity of skill sets and interactions and relationships. And maybe it is too much to expect one individual to do all of this. And I suppose this is what we're talking about when we talk about the reality of leadership. Can one individual really be accountable for all actions and behaviors at all times in the organization? So can you hold an individual, whether that's the CEO or the, you know, senior clinical director or whatever, responsible for everyone's behavior at all times in the organization? Or is this, you know, a nonsense concept? No one individual can assure a patient receives the highest standard of care, nor can he or she protect the patient from all potential harm stemming from increasingly complex and powerful therapies. So Rosen has said this in recent literature. So I suppose in summary, I would say that we can't reach the change we seek one leader at a time. So we are putting too much emphasis on leadership to fix the system. And we need to think differently about leadership if we are to progress and improve safety performance within our healthcare system. And then I suppose what we're thinking about is, you know, healthcare is delivered by teams, and teams are at the core of the delivery of healthcare. And there isn't sufficient focus on the development of leadership within teams. It's been very focused on leaders as individuals rather than the leadership potential of teams. There's been quite a bit of discussion in the literature about how you define a team and what is a team. And, you know, traditionally we think about teams within healthcare as award teams. But, you know, as healthcare has evolved and grown, you have a complexity of different team types at different levels and different sizes. So you have ward teams, you have specialty teams, then you have directorate teams, you can have intra-hospital teams, and now you can have cross-hospital teams in terms of the hospital groups and how they're working. And then I suppose interlaced with this, you have different teams in terms of the professional groupings. And it was interesting when we first started going out into the hospital system talking to people about their teams. Many people were identifying their team as their own discipline only. So, you know, for example, the doctors were seeing all of the different hierarchical levels of doctors as their team rather than the team encompassing the nurses and the HSCPs and others, and likewise for the other groups. So I think it's very complex now when we think about teams and what is a team within the healthcare system. And in terms of the teams that Aoife will be talking about that we're doing some work with, they vary in size from anything from 12 to 70, I think, or 75 is one of the biggest teams we're working with. So it's a very complex environment we're talking about when we're talking about teams.
Sorry, Eilish, just a question that's popped into my head. And we're talking about healthcare here and leadership in healthcare. Has the same thinking evolved in other industries as well with respect to leadership? Are we behind the curve on that, or is it?
Collective leadership is very much a concept in the education sector. It's becoming, I suppose, more prevalent in other industries as well, and in business more broadly. There's been, I suppose, a slower uptake of the concept in the business world because so much has been invested in the notion of individual leaders and these kind of powerful individuals who have the right set of characteristics and traits. So I think, and I suppose in terms of educational institutions, we have a part to play in the sense that I think and I suppose this is what I'm talking about on this slide, is that education and leadership development haven't adapted to the shift towards this kind of concept of team-based approaches. So even in industry, you see a lot of self-managed teams and a lot of emphasis on project teams, etc. But this concept of the individual as leader is still very much prevalent. And I think that's partially because educational institutions haven't caught up and they're only now really recognizing that there's a need for a different type of education around leadership and the notion of educating teams as leaders rather than individuals.
And maybe this might be a time now to ask people online to comment in the chat box around how they feel their work environment is. Are we still in that thinking of the individual leader, or are you feeling that it's moving more towards that more team-based collective leadership approach? If people want to comment on that.
Okay, so again, going back to the notion of the team and the complexity of the team in healthcare, in 1970, the number of doctors and patients seen by the hospital was on average 2, and by the end of the 20th century it was 15, and that's from Gwande's work. And I particularly like this quote from Gwande when he says, "We have trained, hired and rewarded people to be cowboys, but it's pit crews that we need, pit crews for patients." And I think that's very true. We train healthcare professionals to be autonomous practitioners, and then we expect them to operate within a team environment without really emphasizing the nature of teamwork and what's required to work in teams and the leadership roles that different professionals can play within the team environment. Okay, so I think it's about changing mindsets, and it's about shifting our thinking from the notion of the traditional leader as being an individual to, you know, the possibility that leadership exists within a group of individuals or a team. So this is really, I suppose, at the heart of what collective leadership is about, shifting the notion of the individual leader to the collective as a leadership entity, if you like. So definitions of collective leadership in the literature, Tamara Friedrich, who's part of our project team, has I think this definition, there are many definitions, but I particularly like this one where she talks about a dynamic leadership process in which a defined leader or set of leaders selectively utilize skills and expertise within a network, effectively distributing elements of the leadership role as the situation or problem at hand requires. There are, I suppose, several different collectivistic leadership approaches, and people talk about distributed leadership and shared leadership. And collective leadership is slightly different in the sense that it is more dynamic. So when you have distributed leadership, you are delegating roles and responsibilities to individuals within a team, but in a very static way based on their particular skill set. With collective leadership, I think what you're doing is you're utilizing the expertise in a more dynamic way when the need arises, rather than giving people a defined area of responsibility. So this approach to leadership requires flexibility from leaders engaging alternatively in, and this is a really nice way of putting it, I suppose, in moments of give and take, and occasionally stepping back from decision-making and allowing the team to find solutions. So I think embedded in that definition is really the concept of the leader, I suppose the designated leader needing to give a little and to cede power and to enable other people to step up to the plate and take on the leadership role when necessary. This is taken from a website called Leadership Learning Community, and I think it very nicely encapsulates some of the main differences between the traditional individual leadership model and collective leadership. And I suppose just picking out a couple of these, you know, the leader of followers versus the self as leader. So the self as leader, I suppose, is much more focused on the individual recognizing their role within the team rather than stepping apart from it and seeing themselves as an entity outside of the team. It's really, I suppose, about transparent power sharing rather than the traditional approach of exercising power. It's about collective input and process in terms of decision-making rather than centralized decision-making with, you know, one ultimate decision-maker, if you like. And I think, very importantly, the emphasis shifts from individual responsibility, which we talked about earlier, as being incredibly difficult to achieve within a large, complex system, to group accountability. And from the notion of individual intelligence, or all the intelligence being contained within the leader or residing within the leader, to the notion of group creativity and group wisdom and group intelligence, and the concept of collective intelligence, and utilizing that to lead the organization or lead the service. So I suppose in terms of summarizing it from my own perspective, I think the difference, I suppose, is that leadership invested in the individual talks about individual visionaries, whereas leadership invested or being the capability of the collective or the team is about knowledge and expertise of colleagues and using that. Leadership distinguished from followership is the traditional approach, but I think in the collective leadership approach, recognition that there's leadership in all team members, there's leadership capability in all team members, and leadership and followership are more interchangeable than in the static kind of traditional leadership approach. The traditional approach would focus on the leader making decisions based on knowing the answers. And, you know, in reality, no one person can know all the answers. And I think the concept of collective leadership very much buys into that and uses the collective knowledge and the input of the team. Yes, there is a need for an ultimate decision maker, and it doesn't mean that the leader sits back and lets everything happen. There's still a responsibility on the leader to reach decisions, to take action, but using the collective intelligence and the collective knowledge within the team. And importantly, the focus shifts from being on individual impact, which creates a lot of competition in my mind, to focus on collective impact. What do we achieve as a team or as a group, as an organization? And collective impact is something that, if that's the focus of, I suppose, recognition or award or assessment, it leads much more towards a collaborative approach than the traditional kind of competition. So in the traditional model, individual leader oversees the operational requirements to achieve goals, whereas in the collective model, it's the collective or the team that oversees the operational requirements. And ultimately, I suppose, in the traditional model, the leader alone is accountable, whereas in the collective model, you have collective responsibility and collective accountability, thus assisting the leader in his or her ultimate accountability. So it's not that you're taking it away, but that's much more shared. So why is collective leadership, I suppose, important, and why do we feel it is something that can change how healthcare is delivered? We feel it has the potential to break down silos, to encourage people to share expertise, target power structures that are currently there in the system and obstructing change, and we all know about that. That there's greater identification with team and organizational goals, greater staff commitment and engagement, and ownership and acceptance of change and innovation. And many of these things, I think, are things that we traditionally know are important in terms of successful change or successful improvement initiatives. And I suppose the concept of collective responsibility and mutual accountability is a very powerful one within healthcare. You have more integrated and coordinated care with better outcomes where you have that mutual accountability, and safer and more responsive healthcare is the ultimate aim, I suppose, of collective leadership and of this approach. So again, summarizing, collective leadership is not the role of the formal leader, it's the interaction of team members to lead the team by sharing the leadership responsibilities. There's a lot of research supporting, I suppose, collective leadership in terms of its potential to improve outcomes and to improve team effectiveness. And just, I suppose, one final slide before I hand over to Aoife on this. So collective leadership does predict team effectiveness. It's a better predictor of team performance than vertical leadership, for example. And the antithesis, I suppose, is that leadership with a strong emphasis on hierarchy can inhibit a positive safety climate due to the fear of blame and repercussions for reporting safety issues. And I think we're all very familiar with how that plays out in the healthcare sector. The best performing hospitals in the UK are characterised by high staff engagement in decision making and widely distributed leadership. And leadership, Mike West's work has shown this, is the most influential factor in shaping organisational culture, with good evidence of links between leadership, culture, climate change and outcomes in healthcare. So in summary, I suppose that's the argument and the evidence. I'm now going to hand over to Aoife to talk a little bit more about what, I suppose, is involved in terms of introducing collective leadership and how it works in the system.
Great. Thanks, Ida. So we've recently completed a systematic review to synthesize all the literature around collective leadership and shared leadership and distributed leadership that's been conducted in healthcare settings. So this is the first time this has been done, and the literature to date has been quite scattered across several different areas. So there's a great opportunity to bring that all together and learn from what's gone before in building our own interventions. So our review question for this work was, what interventions are the most effective for the development of collective leadership in healthcare teams? What outcomes have been measured? And what evaluation approaches have been adopted in this work to date? So in our systematic review, we searched 5 major databases and also conducted grey literature searches. So this enables us to include PhD theses and other reports that might not be available in the peer-reviewed literature. We screened over 4,500 papers, and we're left with 21 studies that met our inclusion criteria. So these studies encompassed a range of different intervention types. Some were collective leadership for service improvement, some used co-design approaches, some focused on taking the team out and training the team together in collective leadership, and some focused on developing entirely new teams and training them in collective leadership as a team. So I'm just going to go through some of the key findings from our review. The systematic review has been recently accepted and should be available online later this month. We can share that on Twitter and on our website once it's available. But just to give you some of the key findings, importantly, all the 21 studies that were included in our review demonstrated at least moderate success in developing collective leadership in practice. And of those studies, all of them reported positive outcomes for staff, patients, teams, and the organisation. So not only were interventions successful in getting this into practice in healthcare, but they had very strong positive outcomes, especially for staff and the staff experience. So collective leadership was found to be strongly associated with improved communication in teams and enhanced role clarity between team members. Team members also reported enhanced mutual respect, trust, and supportive relationships within the team as a result of the collective leadership being introduced. And importantly, as Eilish mentioned earlier, a greater willingness to adopt leadership roles among those who aren't the formal leader of teams, as well as a give and take by leaders who became more willing to share their leadership responsibilities once they could recognise the expertise that was available on the team. So there's many studies reported increased staff engagement and staff satisfaction, and staff felt more empowered using a collective leadership approach because they felt they had the power to actually change things for themselves where they didn't before. So many studies reported a significant impact on staff stress levels, and reduced stress was observed, as well as significant reductions in turnover as well. So all in all, what collective leadership seemed to do in these healthcare settings was to introduce a more positive working environment. The staff enjoyed more, and they felt they had more power and control over how they were working, and this in turn benefited patients and the quality of care received. So in this part of the co-lead research program was trying to understand Irish healthcare teams in the system at the moment and understand how effective teams can operate within the constraints of the system. So Maria Shea is a member of the co-lead team. We identified basically 4 teams that were identified as working effectively in the Irish health system and invited members of those teams to take part in one-on-one interviews with the research team. So 25 people took part, and we sought to identify the characteristics of effective teams working in the Irish healthcare sector to understand what we could learn and bring forward into our learning for the co-lead intervention. So one thing that was immediately evident among these 4 teams was that there was a culture of collective leadership already there. Interviewees described the leadership they experienced as democratic and inclusive, and team leaders were described as approachable and accessible. So it wasn't your traditional hierarchical structure and style. There's also evidence of strong, supportive interpersonal relationships among team members. There's very much a team-based approach to care delivery, which is characterised by mutual support for each other. Colleagues reported rallying around others when they were in need of help. There was a process of give and take where team members often engaged in role blurring, so where they had the expertise and the skills to do so, they described themselves as venturing into each other's spheres to help one another when the workload became excessive. Teams are also characterised by having an inclusive approach to communication and collaborative decision making. This is a quote from one participant. I mean, no matter what grade you're at, everyone kind of has a say and everyone has an opportunity to get their opinion across, rather than it being very hierarchical. What we see is this person contrasting their previous experience of hierarchical teams with this current team, having a more inclusive experience and a more open experience of decision making and communication, and the benefits that can have for the team and for the patient. Also evident and related to this was a culture of psychological safety. In particular, people described a no-blame culture. So one participant described it as, this is a no-blame team. It's being able to actively reflect on something rather than, why didn't you or you should have. The dialogue is quite different. So again, it's a different way of dealing with events that come up. So rather than avoiding or ignoring things that might be happening, it's having that open discussion about challenges or issues and being proactive in addressing them, and having that comfort to speak up when something doesn't go right or when something is seen or observed that shouldn't be happening. So finally, and these are just some key highlights from research that's going on at the moment, finally, effective conflict management was observed across all teams. So most of the teams and interviewees reported that this is often mitigated by consciously placing the patient at the centre of all the decision making. So really kind of leaving the egos at the door and making sure that everyone's voice is heard to the benefit of the patient. So again, this is very much supported by people on the team having knowledge of each other's roles and knowledge of each other's expertise. So again, a collective approach to decision making, recognising that expertise, and making sure that's fed in as appropriate to the decision at hand. So with this in mind, with the knowledge-based building around collective leadership, our early work identifying the value of collective leadership in healthcare settings, and the work we've done with effective teams in Irish healthcare settings, this is all feeding into our co-lead research program. So co-lead is a 5-year HRB and HSC funded research program, which aims to positively impact patient care, quality and safety cultures through the development of this new model of collective leadership that has been strongly associated with effective team performance in healthcare. So the basic tenets underlying the program is that by introducing and implementing collective leadership in healthcare teams, this will lead to increased employee engagement and enhanced team performance, and that this in turn will impact quality and safety cultures positively. So we know from the literature that it does work in practice. So one of our major issues is how it happens. So there's a lack of knowledge and lack of consensus really on how to get collective leadership in place. We know it when we see it, but what steps are needed to actually get there. So to do this, we adopted a co-design approach to bring people together, bring all stakeholders together, and start with a blank sheet and let people on the ground tell us what they felt they needed in order to get to collective leadership in practice. So just to talk a little bit about co-design, it's a participatory design approach, and it's all about developing a collective solution that benefits all stakeholders to a problem or issue that's shared among everyone. So one of the major things around co-design is that it's very difficult to pre-specify or plan too much in advance. It very much leverages the expertise of the stakeholders in the room and involved in the co-design process, and it builds from them. So for that reason, it's very emergent in nature, and we have to rely on the people and the expertise in the room to help us design the content and prioritize the content for whatever it looks like at the end. And this in turn impacts how it will be measured and evaluated as well. So ideally, the co-design team should have a voice in that too. So it's very much based on the principle that those with a lived experience of working within a health system, those with experience of using a health system, are those that are best placed to help design and refine and improve. So this is our co-design team that kindly helped us with the co-design of our intervention over a 7-month period. So the team gathered in UCD for 7 half-days over that period to really tease these issues out. So we had a kind of a wide range of expertise in the room. We had the co-lead research team. We also had a hospital manager, a medical reg, patient involvement, consultants with expertise in risk and safety, assistant director of nursing, human factors expert, business manager, care coordinator, occupational therapist, 2 physios, and consultants with expertise in quality and safety. So this isn't even everyone that was involved in the team, which is our most complete group picture. And we also had a separate patient panel that advised us on the content of the intervention once the co-design process had been almost completed. They gave us feedback before it was finalized as well. So in terms of our co-design process, we used lots of different activities to try and generate discussion and really tease out some of the issues that we were facing. So we worked to identify the challenges that teams faced in terms of working collectively as a team together. What were the barriers and enablers they'd experienced? What worked well for them before? And just sharing that knowledge and sharing that expertise and working in the system. We also developed an understanding of the support that teams felt they needed. We quickly realized that teams had very little training as a team, and often they didn't know who was even on the team. So often the basics of teamwork were very much missing in the system. We also had lots of discussions around the use of data or the lack of use of data to inform team performance. And we used a variety of methods to keep the sessions interactive, using things like paired conversations, group discussions, and word association tasks to get people moving and get people, challenge people around different issues. So further information on the co-design process is available in a paper that was led by Marie Ward, but written by the whole co-design team. So it's available on our website if anybody wants further information on that process. So in terms of the inputs for the co-design, the researchers were kind of working in the background during the 7-month period, preparing evidence in the literature and collating evidence to feed into that co-design process to inform the conversations and to inform discussions. So this included case studies of interventions from international examples in healthcare, evidence in the literature, so this included our systematic review on effective leadership interventions, a realist review on effective team interventions, and also a narrative review on safety culture. We also leveraged people's experience of leading and working within teams in terms of what was practical and what was feasible for this intervention, as well as looking at case studies of effective teams in the Irish context that I briefly went through earlier on. So all these things were input into these discussions and helped us evolve the intervention over the course of the 7-month period. So through the co-design process, it enabled us to develop a better understanding of the nature of modern healthcare teams in Ireland, what the reality on the ground was, and how we could work with that reality. And so start from where teams are at rather than assume a certain level of development. It also required us to consider the shift required from that individual mindset to a more shared and collective mindset around leadership. We learned a lot around the context of that the local teams are working in terms of the local teams and also organisations, and the barriers and enablers that they felt were present to working collectively. The co-design team helped us identify target areas for intervention, things that they felt were important to prioritise for the different teams, and things that would be common to any kind of team type within healthcare. And then as a team, we designed inputs and we adapted inputs where necessary, prioritised and organised content for inclusion in the intervention. And we also, when that was completed, we had a discussion around the most appropriate way to evaluate this intervention then that we had designed. So Alan was one of our patient reps that was involved in the process, and there's a great video available on our website and at this YouTube link about him talking about, it's only a 3-minute video, him talking about his experience with the co-design process. I think he's a great advocate for the benefit of co-design. I think his voice carries more weight than one of the researchers as well, so I'd encourage you to have a look at that if you get a chance. Maybe if you have time at the end, we could show it. So in terms of what we learned about healthcare teams through the co-design process, I alluded to some of these things earlier on, but we realized that some teams have more stable membership than others. Lots of teams have people transitioning through the team at regular intervals, and makes it very hard for people to get to know each other at all. And then, as Eilish mentioned earlier on, initially people had a very unidisciplinary definition of their team. We go into a surgical team, and they'd identify like a nurse would identify her team as the other nurses, or a doctor would identify her team as the other doctors. We also, through our patient involvement in the co-design process, we found that the patient perspective is often very different to the staff perspective on team membership. So for patients, anyone who they interacted with, they considered a member of the team. So they thought it was very important for us to include members of the admin staff, catering staff, cleaning staff, because these are the people they interacted most with, and often people who distilled messages or translation messages for them from the medical teams and nursing teams. We also found that individuals were very unsure of their own role within the team and often unaware of the skills and expertise of others on the team. So again, just not having a discussion around different roles led to a lot of confusion and often some false assumptions as well. There's also a lack of clarity of the team role and purpose and how it fits with the wider goals of the organisation, and very poor feedback in terms of performance data. So teams didn't know how they were performing, didn't know what their key performance indicators were as a team, and none of that information was fed back to them. So if they don't have that knowledge and that data, they can't seek to improve on, they don't even know what to try to improve on without that data. These are issues we sought to address through the intervention. So the intervention is still being finalized, but what the co-design team decided was that teams needed 6 core foundational elements to take place that we could then build collective leadership on. So these are divided into 3 interventions to promote collective leadership for effective team performance and 3 interventions to promote collective leadership for safety. So each of these sessions, again, the co-design team felt it was very important that these be short, sharp sessions that teams could just pick up and run through, that didn't require lots of advanced preparation, and that could be used within existing meeting times. So all of our interventions have been designed to take place within 60-minute blocks. They can be picked up, just run through very quickly. So the 3 are the effective team performance ones. First one is team values, vision, and mission setting. So it's, again, often teams are so busy with the work of the day, they don't really know what they're working towards as a team. So sitting back and reflecting on that, what are we working towards as a team together? Then building on that, the next one is team goal setting. So taking practical steps as a team to try and address some of the issues on the team and work towards that team mission. So again, this involves subgroups working towards different goals, again, leading the team on parts of the team's work where they have the expertise and motivation to do so. And then finally, role clarity. So this is one that teams have found very useful so far in our pilot testing of the intervention. So often there's lots of assumptions about other people's roles on the team, so it's all about clarifying that, and it's opened a lot of eyes, I suppose, in terms of the breadth and scope of other people's roles in the team that weren't clear before. So those are the 3 core interventions for team performance, and we've got 3 core interventions for safety. So again, all 60-minute sessions. So one is collective leadership for safety skills, so ensuring everyone has the ability to take responsibility for safety at the team level. Another is risk and safety management at the team level, so understanding how the team is performing in terms of performance indicators and safety indicators, and how they can monitor and control those as a team. And then finally, monitoring and communication safety. So once we know what's being measured, are those measurements meaningful, and how could we be transparent around what we're doing as a team in terms of our quality improvement efforts? These 3 interventions, very interlinked, help the team get, I suppose, up to speed on what they should be, what they feel they should be monitoring in terms of safety. So the next step, at the moment, we're in the process of finalizing these interventions. So what I shared with you today in those last 2 slides was the 6 core intervention components, but there'll also be up to 15 further targeted intervention components that teams can select based on their goals, based on their priorities, and based on their team type and what's appropriate for them. So these interventions components will be available open source on our website in the coming months, and we're hoping to do another QI Talk Time webinar to launch those in the coming months as well. At the moment, we're finishing up our pilot study of the intervention. So we're working with 4 teams in the R&D hospital group, 4 very different team types, to test and amend and evaluate those intervention components at the moment. We'll be doing cross-case comparisons to understand how different organisations and different sites may be impacting on the intervention, and also how it's being used in different team types, and what's working well, maybe what's not working so well. So the plan for later in the year is further large-scale testing of co-lead within 2 major hospitals, and this will be subject to a large quantitative evaluation then. So just finally, I just want to briefly bring you through our website. So the website address is ucb.ie/collective leadership. There we've got further information about the project and its aims, and there's lots more about the methods that we're using during the co-lead project, including more in the co-design process. We'll be hosting and linking to all our publications as they're made available, and that will be made available through our resource hub. And on the resource hub, that's where you'll find our intervention components once they're made available as well. We'll just give you a snapshot of what those will look like when available. They'll be divided into different sections: collective leadership for team performance and collective leadership for safety. You'll be able to click into one of these and get further information on each component, including the aim, the expected outcomes of the intervention, what's involved during the session, what's the existing evidence for the intervention, and then clicking in further, you can download the materials in PDF format. So these are things you'll be able to facilitate notes and maybe handouts for the team. You'll be able to pick up and run through very quickly, very structured with timings and structured questions and activities as well. So there'll be different levels of interactivity and different types of activities within each of these sessions, as is relevant to the different topic at hand. So finally, I just want to acknowledge our funders. So this research is funded by the Health Research Board and supported by the Health Service Executive, and we're conducting this research in partnership with the R&D Hospital Group and with the King's Fund. So I might just throw over to Eilish now to just focus in briefly on the other kind of work going on within the team.
Okay, so just to follow on from what Aoife was saying there in terms of the development of the intervention components and sharing those with you at a later date. We also have an associated project, the HRB Knowledge Exchange and Dissemination Project called Team Talk, where we're really working to try and make these, I suppose, components as user-friendly and available as possible, and looking at how we support teams in terms of downloading and working with those. And some of that work involves recording and taking the learning from the existing pilot teams that we've been working with, and encouraging those to share their experiences with other teams in the system who might want to take on board some of these interventions and introduce them into their own teams. So the program is quite an ambitious program. As we said, it's a 5-year program, and it has many different components to it, because we're not just, I suppose, making a case for collective leadership, but we're also looking at how you do it. As Aoife said, there was nothing in the literature about how you introduce it to teams. We're testing it with different team types to see if there is one model that fits all, or if, I mean, we have, as Aoife said, core intervention components, but we are allowing a great degree of flexibility, and we're looking at different team types and how they work differently in different teams. But we're also looking in great depth at what does work within teams and how teams work and how teams take up initiatives like this, or any kind of new approach to doing their work, and how that can be effective within the team. So on the screen you can see the team members, and I suppose just to point out that there are 6 PhD students working on the project, and they all have very different topics that they're working on. Lisa Rogers, who's on the screen there, is working on implementation and context, and looking at how context influences interventions in healthcare settings. So using the co-lead intervention as a case study to really identify within 2 different teams whether the context of the team, the size of the team, the organization they're working with, the history of the team, how that impacts on how the intervention is taken up within the team. Tony O'Brien is working on leaders' behaviours and espoused versus enacted values and behaviours. Una Cunningham is looking at team interventions in healthcare and really using a realist methodology to understand in great detail how interventions work in teams in an acute care setting. Zanira Khurshid is working with the QIT team here in the HSE looking at quality measurement and measurement for improvement, and really looking at the curriculum that's being delivered around that and how that is influencing improvement within the system, and whether it's being sustained and spread by those people who are involved in learning measurement for improvement. Sylvester Rowan is doing a lot of the modelling work, where we're doing a large, I suppose, evaluation of the collective leadership intervention across the 2 hospital sites that Aoife mentioned we're scaling up to, and really looking at what are the, I suppose, variables that link with what. How does collective leadership impact on team performance and on patient safety? And what are the various variables within the system that contribute to that, you know, such as staff engagement? Does it influence job satisfaction? Does it influence patient safety outcomes? So the real kind of critical questions around whether this is an effective approach. And then finally, Sharon Gorman is working with the IEHG, looking at the public and patient involvement in collective leadership, and really trying to develop a model within a hospital for how you engage with the public and patients in the total hospital system, and how that ties in with the collective leadership approach. So thank you very much. We're happy to take any questions.
Yes. So back over to me again. So thank you so much, Eilish and Aoife, for an excellent presentation. I'm sure the content resonated with a lot of our listeners online. I suppose what I find very encouraging listening to your talk was, you know, your research into what actually is currently happening and how a lot of teams currently are, you know, showing signs of collective leadership already, which is really encouraging. But I suppose it is interesting to now work on how. So if you don't have it, how do you go about getting it? And I think we'll all await all of your tools to assist with that. But just one of the things that kind of came up in questions in my head while I was listening was, you know, in terms of the environment in which these teams are working in, has there, just interestingly, has there been any resistance or, I suppose, reluctance from leaders, like heads of departments or line managers, around this type of thinking? Have you come across anything like that?
I think we've been quite surprised at the positive reaction to this. We expected that. I think there is some difficulty getting one's head around the notion of collective accountability, because it's so kind of ingrained in our thinking that the leader is the person who's accountable for everything that happens in the system. But I think once people can kind of grasp the concept of collective accountability, you know, and I think leaders begin to see that this approach doesn't threaten their power or autonomy in any way. It actually helps them to do their job better, because they're utilizing the expertise within the team. And I think once people grasp that, there isn't any great deal of resistance to this. You know, the I suppose, problems we've had have been, and they're classic within the healthcare system. How do we find time to do this? You know, where do we meet? Who should we involve? You know, what is our team? They're the kinds of things that we're dealing more with, I think. And that's why we have done quite a lot of work with teams, both in terms of the research work, interviewing existing teams, but also involving healthcare professionals in the co-design process to really help us to understand the constraints that they're working within. And I suppose that's one of the key differences in this program in terms of traditional leadership programs. Take people out of the system and bring them into an academic environment or some kind of protected environment and train them. And we're saying you can't do that with teams, but the team is the entity that we want to train here. So we have to go into the system where they're at and work within the constraints of that system. And that's why we're making sure that all the intervention components are an hour or less, and that they're delivered either during lunchtime journal clubs or, you know, morning meetings that people have. It varies in the different hospitals. We're trying to deliver within an existing structure or an existing forum, I think, is a key part of what we're trying to do here. I think the other thing that has come up, and I suppose we both alluded to it in terms of the presentation, is this concept of team and what is a team. And I'm involved in several teams, and how do I identify what my team is, and how do we get 74 people into a room at one time to deliver this intervention? We won't, and it isn't our intention ever to achieve that. But I think what we're trying to do is change the mindset and really get across the notion of working collectively towards a common goal and embedding the tools and techniques in some of the team so that they begin to work in that way and that way spreads. And I think what we found actually in terms of the teams that we interviewed is that's what happened organically anyway. So there were people who were, you know, recruited into teams that already had a collective approach, and they very quickly learned that's how you work in this place. And I suppose we're hoping that that is what will happen within the teams that we're working with. Not that we will get 74 people in a room consistently over the space of, you know, 8 to 12 months, but that we will get enough members of that team for it to become the natural way that they work together, and that will then spread. And they will spread it in turn to other teams that they're involved in.
I think that actually answers one of the questions that came up on the chat there from Liz, you know, that whole thing of how working in a healthcare setting you actually are a member of multiple teams and they're all connected and how, and I think you've answered that in terms of developing
one
that.
of the key learnings with lots more inclusive effective teams we found is that when new people joined the team, they're forced to adapt to the team or else they didn't ask. So that team culture remained consistent once those things were in place. That kind of protected the team, and people didn't want to leave the team once they had that in place. So it's about new people adapting to that culture, and that's in that way kind of protecting. And one of our teams said we're future-proofing the team. So when we do have lots of people transitioning through the team, they can adapt. This is our way of working as a team. This is how we operate, and so people can adapt to that kind of culture.
Great. An interesting question from Catherine Whitty. Just saying thanks for a very informative presentation. But have you planned to test any of this in a community setting?
Okay, so in terms of our existing teams, one of those teams is a team across hospital community. So it's a new team that has been formed to kind of integrate care for older people across the two settings. We're also working on a proposal to test it specifically with community teams. And that proposal is going in as an APA, an Applied Partnership Award submission to the HRB in this current round of applications. So that's specifically to take 2 community teams and test it with those. Because although we have teams across hospital and community, our focus on the pilot has been much more, I suppose, in the hospital setting, and we're recognizing that, you know, this needs to be an intervention that is relevant to all teams. So that's the plan there.
Great. One other thought, you talked about patient involvement, and obviously in hospitals, patients aren't naturally members of a team per se, but as you've laid out your interventions that you have, your 6 interventions, are patients involved in any of those, or is it purely just the healthcare team?
So what has happened, I suppose, so far is we had patient reps involved in the co-design process. And then we ran a specific session with the intervention elements and tested it on a group of patients to get their reaction to that. But I think what we haven't done yet is the intervention, the pilot teams we've been working with, they haven't involved patient representatives. And that's something that Sharon Gorman's PhD is addressing. How do you then get the healthcare teams comfortable enough to bring patients into that, into their intervention session? So I think that's the next step for us in terms of making that happen in a practical way within the hospital setting.
Plenty of work. There, keep it going. Maureen Flynn is in the room here, so I think you have a question, Maureen, as well.
Thanks very much, Roisin, and hi to everybody online, and thank you to the fabulous presentation. Top of my mind at the moment, and the collective accountability is lovely, and to hear that you've moved to an understanding of it, I think is really fabulous. In some of the patient safety outcomes are obviously what you're looking at. Some of the professional discussions around at the moment are around patient safety bills and how that may support or create obstacles for you in terms of collective accountability. I don't know if you had thoughts on that, or how is it being incorporated within your research?
I mean, I suppose because the research started before that, we hadn't seen it as a barrier. And I mean, I'm not sure that it is going to change things that much. I think that it is not contradictory to what we're proposing here. I don't see it as such unless you do.
I think some of the regulations that are emerging from the Civil Liabilities Amendment Act and the forms that are used are asking for a principal health practitioner to sign in terms of open disclosure processes, which is moving out of the sphere of collective accountability to individual accountability, and just how that might sit.
I mean, I think it's similar to a question I think I got asked I can't even remember where it was, but recently was asked the question, are you suggesting we get rid of all leaders? You know, and I suppose it's similar. You're still going to have an individual who has ultimate legal accountability. And we're not suggesting that that changes as such. Yeah. What we're saying is that, you know, there's accountability. Every individual has accountability. And at the moment, you know, every professional is trained to be accountable. And we think about our professional autonomy and accountability in that sense, in terms of our own professional practice. And it's really just extending that into the mission or the goal of the team, and saying I'm accountable for this goal in as much as I'm accountable for how I practice individually with, you know, individual patient care, etc. So it's really broadening people's own concept of what they are accountable for and taking it beyond the professional boundary into the team entity. But it's not really saying, I don't see it as being contradictory to kind of legal accountability within the system.
You would hope it would be complementary.
Yeah.
That's what
yes.
That's true. I think maybe what I'm just doing is signposting the kind of thoughts around and that's how the research can reveal them.
Yeah.
We're coming up to 2 o'clock, and I know you all have your other work to get back to, so we're going to squeeze in one more question from Liz Kelso, and she's asking around, is there any evidence to suggest how long it takes for a team to become embedded and reach their maximum effectiveness? She's saying in terms of movement of staff, can a team reach their full potential within a relatively short time frame, or does it depend if the team members are bringing transferable skills from previous team experience?
That's a big question. It's a smart answer, but it depends on the team, really. And I think if you have a core membership of a team, if you have 3 or 4 individuals who, you know, have, I suppose, this way of working, and it's firmly within their kind of psyche, if you like, that's enough to sustain, even if there is movement in and out of the team. But if there's a lot of movement and it's reliant on one individual, if the leader is the only person who sees a collective approach as being important, and the team, you know, is a team that has come from a very traditional hierarchical way of working, then it's going to take longer to shift that mindset. But, you know, I think if you have, I think there's this concept that Patrick and Kel, who runs the Collective Leadership Institute, talks about a container for change. And it's really this notion of, if you want to embed something in the system, you need a small handful of committed people who believe in the approach. And I think it's the same with the team. If you have a small handful of people within the team who are fairly stable within that team, they can, you know, sustain the collective approach within the team, regardless of whether people are moving in and out. And going back to what Issa said, you know, we saw where collective leadership is firmly embedded in teams within the system. And maybe there aren't that many teams where it is in place, but the ones that we've looked at, it certainly is surviving because there are a handful of people there that, you know, believe in it and see that it works for them.
Okay, fantastic. Well, you'll see that we have the addresses here, the email addresses for the COLE programme, and both for Eilish and Aoife. And I just want to say thank you again for an excellent presentation, lots of food for thought, and we'll await all of your tools and definitely schedule another QI Talk Time as a follow-on from today's session. We had 48 people online at maximum, which is great for our first talk time of January. Everyone's getting back into work. So our next talk time is Tuesday, today fortnight, and we're delighted to have Anne Kilgallen from Northern Ireland. She's going to talk, and I think it follows on quite nicely from today's talk, around building your own networks for improvement within your own organisation from top to bottom and bottom up. So hopefully you'll be able to join us for that. And we do then, the follow-on sessions are going to be on the After Action Review tool and I suppose practical tips and tools for people on how they might use that in their workspace. So we'll have that scheduled for the next webinar after that. So thanks a million for joining, and thank you again to our speakers, and we'll see you again soon. Okay, thanks.